Yorkshire Integrated Care Board. Welcome everybody who is joining us online today. Got a number of participants joining us as well for various reasons. This is a meeting in public, not a public meeting, but really welcome and happy for you to observe our business today. So in terms of apologies for this morning's meeting, we've got Nigel Wells, but James Frick is here as Nigel Wells. Victoria Lawrence from Adult Social Care, Amanda Bloor, Karina Ellis and Louise Wallace is joining us online, but will need to leave to go to another meeting. I know other people are in and out today. And Tracy Meyerhoff from Hull City Council will be joining us at 10 o'clock. And I think Lynn Simpson, our Collaborative Acute Provider representative, is joining us online. And also I think Merlin Jones from Children's Services and Andrew Bennell from the Community Collaborative. So welcome everybody. So that's probably the most exciting thing in the meeting is the who's doing what. So we're going to go to register of members' interest just to note. So in terms of the members' interest, it's just to note the things from the interest register. And also, are there any declarations that everybody needs to make in terms of the business of this meeting? So I think all employees of the ICB, the chair and non-executive directors declare an interest in terms of the transition update. If there are any other interests that we need to declare during the meeting, if people can just say, and we will work out how to deal with them. Okay, and gifts and hospitality. There's just full transparency, the gifts and hospitality declarations that we've had, that's just for the information, but I think, Stuart, that goes through audit committee as well. It's just for the board information. Okay, can we go to minutes of the last meeting? And before we do that as well, if you are using a laptop today and saving paper, unlike me, can you make sure that the sound is off? Because there's nothing more exciting than the ping of emails that people are getting, and clearly some people are more popular than others, is my comment. So if you can just keep sound to a minimum. Okay, if you go to minutes of the meeting on the 10th of December, and we'll go through first of all corrections and accuracy, and then we'll pick up masterising on the action list. So pages 1, 2 and 3, 4 and 5, 6 and 7, and the action list is page 8. So are people happy pages 1 to 7 as being a true and accurate record of our meeting in December? Huge thank you, Michelle and Emma, for kind of pulling together those minutes. They're really good. Just go on to the action list, which is the matter arising. So this is the one that's been going around for a while. I'm conscious this is Nigel's action and Nigel isn't here, but this was around the governance arrangement for the commercial sponsorship of activities and joint working with the pharmaceutical, medical appliance and head technology industry policy. A snappy titled policy. And the update is the process was in place for all sponsorship agreements and declarations to be included on the corporate register. This register was reported directly to each ICB audit and governance committee, and we see the interest register here as well. So do we consider that item is closed? Quite a historic one, so people are happy with that. We will close that item. Okay, I've not been notified of any other business for this meeting, and there have been no questions this month from members of the public. We did receive a question, just to let people know, just beyond the deadline. We'll pick that in the future, so we will respond to it, and then we will receive that in public in March. Okay, so we're going to move on to the board assurance framework. So there's a report attached and a copy of the board assurance framework. I think the final version is the one that you should have had in your packs. And I'm going to go to you, Jane, in terms of presenting this.
Yeah, thank you, Chair. I mean, the report speaks for itself, I think, in terms of working through and seeing what the updates were. I know there were some challenges with the timing of the meeting, getting some of those updates in time, but we also knew that was going to be a challenge. So if I just take you through, sorry, to me. board papers, it would help, wouldn't it? If I just take you through the cover paper and highlight some of the things for you to be conscious of, and then happy to take any questions. So the first one to come to under section 3 is A1, which is the patient safety. Amanda, you may want to add anything in on here, but we have determined through our executive committee that we're going to have a closer look at quality because of some of the challenges we've got. And you've notified that risk is going to be updated. There's a timeout session I know that you've got in January. I don't know if there's anything you've done.
So if that's all right, Chair. Thank you. Thanks, Jane. So we had a timeout Monday. We looked at 3 specific topics. One was around risk and risk management, and we talked about risk in terms of both provider risk and our own internal risk and how we manage that. And we had a conversation about how that then links to the board assurance framework in terms of informing where we are with our strategic, the risks around delivering our strategic objectives, and how we use data. So that was the second bit in terms of how we use the integrated performance report to assess that level of risk. And then the third piece was around how we embed our approach to quality through a commissioning lens. So that was the first time out. We're going to have another one to build up on that, and at some point I will bring that back here, Chair, if that's all right, share with board members in terms of that approach. But we felt that then we needed to do some more work on the board assurance risk around quality, which we'll take to a quality committee, Mark.
We will. and I think probably my reflection would be is that I think the board has become much stronger around the quality conversation that sits alongside performance and the money. And I kind of think from that, inevitably there's a question around quality and the impact of performance as it stands at the moment on quality. So in some ways, I think it's the right time to be reviewing that risk level based on where we are now as a system. So I think, I really welcome that passage through the quality committee back to the board. But I think that's probably the realistic picture we have, and I think you covered it in your presentation at the last meeting around the things we needed to be concerned about as a board. So no, that's really helpful. Any other questions around the quality one?
It is worth pointing out to everybody, in case you're on the wrong paper, that there is you got a paper initially that had a lot of updates still to come, and then you've got an updated version, didn't you? So it's the
boxes filled in.
With all the boxes filled in, yeah. So it's the updated version. I only noticed, Mark, because I could see what you were looking at. You're on the wrong paper. So A2, delivery of the operational plan. There's no significant updates to that. The score is staying the same. I'm mentioning these because there's quite a number as we go into the last quarter that still remain out of appetite. This is one of those, of course. And then A3, the financial resource, that again has remained unchanged, but the risk does remain out of appetite still. And the same with the financial resource, although that's got an increase in the risk rating that will go through finance performance and contracting days. It hasn't been through there yet.
No, it has been. So
okay.
It will come up later in the insights report. So it was agreed by the finance committee in November, I think.
Yeah.
Okay.
So I think we can cover that one off now. You're looking to increase the risk score.
The system risk score, not the ICB risk score. Yeah. So the ICB one will remain the same, but the system risk score around the control total because of the provider forecasts going out as was signalled in December.
Which has gone from 20 to 25.
But I suppose within that one as well, I suppose we can probably take that now in terms of it's a path thing, isn't it? Mm. Is that actually based on the information you presented consistently and the advice and recommendation of the committee, the board is being asked to increase that from 20 to 25. Right. That reflects where we are. Does anybody have a violent opposition to increasing that risk to 25 on the advice of our committee?
No.
Okay, you're increased.
I assume Simon will talk to that as well when he does this.
Yeah.
Okay.
Again, the next one, no updates, risk remains out of appetite. Then we move on to delivering the future model for the ICB. And the transition piece, we've not changed the risk score. Again, that one's out of appetite. Workforce availability, no significant updates. And the same, so the governance and controls, we've increased the risk from 12 to 16. So that remains a consideration for the board today, moving that from 12 to 16. There's some gaps in control and assurance, which has led to an increase in the risk rating.
So that's another one where we're going from 12 to 16.
That's right, yeah.
Because of those gaps. And that's on the advice in terms of governance and controls. So
Yes.
are people happy to increase that? Okay.
So I just think it might be worth talking about any of the actions to address the gaps in
Yes.
Yeah.
control. So the
Yeah.
expectation of when that will
Yeah.
be
Just what-
reviewed and
yeah, the mitigation.
mitigated.
Yeah, I think there's a plan that we will bring to a future board around that, because we're doing a review of and it's tied up in the transition as well as use arrangements.
Yeah.
Yes.
Yeah. And in some ways, highlighting the risks at this stage then is very helpful in terms of looking at New Look ITB, isn't it? So
Yeah. It is, yeah.
you know, these risks actually form the basis of where we head to next, don't they? Which is good. So we'll expect something back on that one.
Yeah. And then the next one that's got one for the board to consider is C3, which is the data and digital maturity. So on that one, there's been a new gap in control and then therefore an increase in the risk rating. And that's suggested to move from 12 to 16.
And we're assuming with that one that similarly there'll be some mitigations that will come through the digital
Yeah.
committee.
Yeah, exactly that.
Around that.
Yeah.
Okay, are people happy with that shift there as well? Okay, so that's the BAF update. And I appreciate the timescales around the BAF thing. I think it was Christmas, New Year, and then can you update?
Yeah, the date for it, yes and no.
Happy Christmas, can you do the BAF? So I do appreciate this. This has been a real challenge. So everybody who's kind of helped pull this together and get us to where we are with a full BAF today to kind of look at, I'm very appreciative of that. So thank you. So we've reviewed it, we've approved those changes, and we will see those coming through, I think, in the insights reports as well, which is the assurance around how this is coming up through committees, which is good. Okay, so you get a brief break, Jane, because there's no governance items reserved for the board, usually. So you get a bit of a break, and we move on to the Chair's update report, which you've got in your pack, which feels slim because we did an update in December, but just a couple of things to pick up. So one of which is, to inform everybody, if you don't know already, because I think it's probably the worst kept secret in the world, Teresa's appointment as our substantive chief executive. And I just kind of wanted to say that I think from the ICB point of view, I think stability, continuity in terms of our leadership, I think in terms of being able to support the organisation as we move from delivering this year's plan into the transitioned ICB. I think, Teresa has demonstrated very, very strongly over the past 9 months that ability to balance the two. And I think where we are now as an ICB is a immensely positive kind of position. I think that's down to Teresa's leadership and the work of the executive team and all of our staff and the work of this board as well. So really pleased to be able to announce that just before Christmas. And I think anything you wanted to say?
Sorry?
I think we're just
I welcome, no, in seriousness, all seriousness, because I've said this to the staff at our staff briefing. It was a real privilege to actually be in the acting position for those number of months. And that in part, what we've actually been able to achieve despite all the transition work and all the concerns about the future and the challenges, I think is part of the reason why I then applied for the job.
Yeah. So I think it puts us in a really strong position and I think brings a confidence to the work of the ICB. I think it has been a challenging year, but I think the leadership of the board, the executive team, and Teresa as the acting chief exec, I think has enabled us to get to where we are now. So I'm really, really pleased about that. The other thing to note is that you will have received a stakeholder update to let people know that Karina Ellis, our Director of Corporate Affairs, will be leaving us at the end of January. And I just kind of wanted to formally recognise the contribution that Karina has made to the development of the ICB right from the early stages. And some of us will remember working with Karina when we were an STP in those days when we were STP. So very much, a thank you to Karina and best wishes for what comes next for Karina. But that will be the end of this month. So I do a brief update there, and I'm not going to go into any detail around the organisational change and transition, apart from to say the consultation closed last Friday, and we are now in the process of kind of looking at the responses to consultation and how that feedback then helps us shape the final structure. I think the plan around this is also then to have those wider stakeholder conversations around what the new model ICB looks like, actually what the mobilisation will be, and actually to start to think around how that new model then supports our existing work and our existing relationships. And that will be a priority kind of piece of work for me and Teresa over the next couple of weeks. But Jane will pick up on all these around the transition. And then just to say, and I don't know if you've got great detail about it, we might pick up later, is that we did submit the medium-term operational financial plan after our extraordinary board meeting. It was the following day, I think, Sean, that we submitted on time. And then on Christmas Eve, we were invited to a meeting with NHS England, which was on Monday this week. So Christmas present was an email saying you will come and meet on the 12th. I mean, Teresa will give we'll give some feedback on it, but very much it was an assurance process, I think, looking for us and also for our providers to kind of look at their plan submissions, which is helpful feedback before we get to the final submission, which is in February. What's the date in February, Sean?
February the 12th.
12th of February is when the final version kind of needs to kind of go in. And then thank you to everybody around this table who will be supporting us on Friday for our roundtable session with the Whole East Yorkshire Mayoral Combined Authority around the interface between the Combined Authority and the NHS across Whole East Riding, which very much I'm terming as a first day conversation to kind of understand the work that we can do together, but also I think some really helpful thoughts around that whole prevention and neighbourhood health kind of agenda, which I think very much chimes with the vision of the Mayoral Combined Authority. So we will be doing that on Friday. And then I suppose the other thing that's not in the report, but just to kind of let people know, is that one of the things you will note from the 10-year plan is about the ICB's future role in terms of innovation and health innovation. And Jane and I have had a useful meeting, I think, with the Health Innovation Network for Yorkshire and Humber to start to tease out what that might look like in the new world, and actually how, despite the constraints of £19 a head, I think there's a lot for us to kind of go at in terms of that innovation kind of piece of work. So it isn't about standing still, and actually that piece of work is quite exciting. So we'll bring in some proposals back to the board around our approach to health innovation fairly soon. And that was all I was going to say in terms of that, unless people have any questions. Okay, so Teresa, over to you.
Yeah, thank you. So shall I pick up the meeting on Monday, which obviously isn't in my written report because of the timescales. So as Jason's alluded to, the meeting that we had with Region was an assurance meeting, and just for everybody's understanding, we are in a very different year in terms of the planning round, with Region taking an assurance lead. And that was the purpose of the meeting on Monday. And they will be having a series of touch points, I think, between now and February the 12th, when submissions are made finally. I think, and we'll talk in more detail later, we just need to recognise that it is a new world in terms of the financial rules that we're going into, with the withdrawal in totality of the deficit support funding arrangements that we've had to date. So we're already at, a financially challenged environment. Therefore, we can't deliver everything that everybody would like in terms of, I suppose, financial envelopes for every organisation across our patch. What we have done, and we shared at the meeting with Region on Monday, is we agreed principles that guides us through some of the very difficult conversations that we have had and will continue to have to get us to the 12th of February position. And key for us as an ICB is that we're still thinking system. We've still got our responsibilities around population health, the system perspective, the eye on inequalities. So that's guiding a lot of the conversation that we are having. Because obviously, and you would expect, each organisation is looking from their own perspective. We've got a responsibility to make sure that we look across the system. We have got quite a bit of work still to do. We've got a lot of work to do around truly understanding activity, some of the demand position, getting agreement across providers on their expected profile of demand, for example. So there's a number of workshops that we're going to be having with providers collectively, so that as a system, we've got the same understanding of the different parameters that are going to be important as we get to a conclusion of the planning. And that's in addition to the one-to-one meetings, where we'll be obviously looking through the detail with each individual organisation. So that's all I want to say on that.
And then the final version of the plan will be formed by all of that work, and then we'll come back to the board.
It will indeed.
For sign off. So one of the key things, I think the interesting that are keen to understand is the board level of understanding and involvement in signing off the plan. And I think we were able to articulate very well the number of times the draft have been through this board, and I kind of think that is exactly the scrutiny that this kind of needs from providers, from partner members, and I think it's a really helpful process that we ran, and we will do something similar in terms of that final submission in February.
Okay, so I'll come to Sean in a minute, who can update on the industrial action and the various sprints that the ICB and organisations are going to be doing in coming weeks. But I just want to touch on the mental health bill, because it's something that's quite dear to my heart in terms of some of the things that I've done in the past. But it is quite significant in terms of the shift in approach. And I'm sure Michelle will have a view about some of this. But I think we've teased out in this report some of the headlines that will be important for the ICB to make sure that we are in a position as strategic commissioners to actually ensure that we deliver on the key parts of this mental health bill, which, as I say, I think from an individual patient perspective are really, really important. And particularly the detention criteria, actually having a therapeutic intention behind somebody being admitted to a mental health institution. When you say it like that, it sounds obvious, but that's not always been the case. So I think that's quite a shift, and one that we need to make sure we're ready to provide both the commissioning leadership around, but also the assurance and oversight of.
Can I just ask a question? If you finish there, Therese, it just, I've kind of seen the level of detail that's in the report, which all looks really logical and helpful. Just thinking in the context of things we've talked about at Quality Committee, about incident that happened in Nottingham with a patient, without me naming names, and some of the things we need to think about around that. Does this fit with what we need to do in that broader context, or do we still need to do a bit of work to find out how that all hangs together?
Can I pick that up?
Yeah, you can.
I mean, first of all, thanks for that. I was quite surprised to see some of the detail in this. I think for me, the clarification is what is the ICB's role, because the ICB's role is as an assurer, really, that the providers are actually implementing the 25 Act properly, because it was all sent in December the 18th. There's actually nothing in there that we don't already know or we've not already projected, because this has been ongoing for about 20 years, to be fair. There is a first tranche of work that needs to be done by the 18th of February, which is around conditional discharge, potentially with deprivation of liberty / don't need to go to court for protection. We've done some work on that. Working with the local authorities, we think they'll have very limited impact on us at the moment, but that's the first thing. The implementation plan is going to be 10 years. So we need to be careful that we haven't got any detail yet from the centre. We've got the document, we've been through the document in forensic detail. And obviously from a collaborative point of view, we'll work with the other providers to see how they're doing. So the first thing that we're going to look at is but clearly that's ICB, is to check that from the 17th of February Act provision is being implemented correctly. In relationship to Nottingham and others, that's the quality aspect. That's around how do providers ensure themselves that if people fail to engage, and there's lots of work on Nottingham around assertive outreach, because under the previous national standards. There were what we call assertive outreach teams, which worked with particular service users and patients that didn't engage very well with services. And they've morphed into different things because they actually didn't potentially work very well. They were very good for those that got through into assertive outreach, but not necessarily for the larger scale population. So, for example, in our organisation, we don't have an assertive outreach team, but we have what's called CIPHER, which is similar. Which is for the difficult to engage. So what the RCB needs to do from a quality perspective is to assure itself that providers are dealing with those patients that fail to engage, because that's the main thing.
Yeah.
There's lots of other things about Nottingham, quite frightening piece. But when you look at Essex as well, there's quite a lot of similarities around that. So there's the quality piece of what we're currently doing now from a provider point of view, which the RCB will need to assure itself from a strategic commissioning point of view. And we need to work out with region what they're going to strategically assure itself on as well, because I'm not personally the provider reporting into two individual organisations, and I've had this conversation because we have got the staff to do that all the time. So we need to deliver what we're going to deliver. So when we sorted all that out, that's for me is the assurance piece, and then the assurance that the Act is being implemented, because there's very little implementation for the ICB to do. It's either between the local authorities, the courts, or the providers that do the section in the first place. Is that helpful?
It is helpful. Thank you.
We've done quite a few papers in the organisation, our organisation, which I can share if that's helpful.
And I think that, before I bring Lynn in, I think that core understanding of the ICB role moving forward is incredibly important at this stage. Lynn, lovely to see you, by the way. Oh, you're on mute.
Thank you. Yeah, I've come off mute now. So, and again, apologies for being late to the meeting. I'm really heartened by this piece of work that's going on, and I think it takes us in the right direction for this group of individuals. But I'm just wondering, and it's more of a thought than an actual question. This relies on us all working in a really different way and much more closely together. So I'm wondering how we'll take it forward, Teresa and Michelle, thinking about particularly ED departments and when patients present with mental health issues, and then we go through various processes there. How do we change that to look at that therapeutic intervention or therapeutic intention, as Teresa was saying, because it's a completely different approach to the current management, isn't it? I'm not sure we've got the skills. I'm not sure that we understand how that will work in practice. And the final part is I've also heard about the development of the mental health ED departments. Is this linked in any way, or is it completely separate?
That's what I can answer. I mean, it is completely separate. This is just the Act about how we detain people. Because at the moment, if you remember, there's been a lot of conversations over the last at least 10, 15 years around the 83 Act not being the right Act to do, and it needed to be updated. So actually, it's taken that long. There's been lots of conversations. So actually now it's come through the other side of that process. So that's about the technicalities of how we detain people. And there is a lot more emphasis on service user involvement, relatives involvement, not having the nearest relative, for example, having a nominated person. So it's a lot more inclusive, and the detention periods are reducing. So from 6 months to 3 months for the first period, and then a second period, again, 3 months. So there's a lot of more emphasis on that inclusion piece. And the biggest aspect to the 25 Act is the aspect of learning disabilities and trying to separate them from the mental health detention type process. So that's why it's going to take 10 years. I think in relationship, the ED part that's in the guidance is really following what we've done actually, Lynn, at Huff, which is around making sure that all mental health services have a direct streaming into ED for mental health services, so they can be triaged at the point of access and they don't have to go into the main part of the ED department. So that's an operational now. There's a whole massive piece of work. This year is going to be mental health all the way through. I'm not saying acute, that will continue to be there, but there are so many pieces of work ongoing. Penny Dash is leading a lot of them as well, but one of them is around the modern service framework for mental health, which will include things like the ED provision and how we work closer together, and how we really start to integrate it with neighbourhoods and how we integrate it with the wider primary care piece. And the first part of that is a task force that's been set up to look at the supply and prevalence of mental health services, which is a huge task. They're looking at absolutely everything at the moment, and getting a lot of data crunching, and then they'll pick out the top bits for that. But that's about how we work closer together in partnership. So there's lots of different strands to it, but the ACT is just the technicality piece about how we actually detain people. Is that helpful?
Very helpful, thank you.
Very good. And I think one of the opportunities we have through strategic commissioning kind of moving forward is about how actually we move away from those silos into a wider conversation around mental health across our system, because actually mental health is part of every bit of work that we need to be doing. And actually, some of this is the opportunity we've got to be creative and innovative in what we do, building on existing good practice. And I think that's the really important bit. Because some of this stuff is happening. It's not saying it isn't. The assurance bit is about understanding and knowing it's there, isn't it? And I think that's the important bit.
So not to prolong the discussion, but I think fundamentally, this is a really significant cultural change for mental health organisations in how they and actually how we all view and manage and make provision for individuals with a learning disability and autism. I think we've got to recognise that that's what it is. It's quite fundamental change. Okay, just sorry. Not finished. So obviously we have a big focus on waiting times, and we've now been asked to undertake some sprints to improve the position towards the end of the financial year. So I'm going to hand over to Sean to pick up both any final comments on the industrial action that we saw before Christmas. And I know we touched on it at the December board meeting in anticipation, but then also to touch on the sprints that will be happening between now and the end of March.
So resident doctors are a warm up, and then you can start to sprint, Sean.
So on industrial action, at the last board we reported at the time that there was a few days ahead around the industrial action timing, and there was particular concern about the timing of that particular period of action, sandwiched between the increasing urgent emergency care pressures compounded by rising cases of flu and other things, and the proximity to the Christmas period, which would therefore present a challenge amongst other things around the target of getting to as near as possible the 80% bed occupancy figure that was set by Jim Mackey in September, in order to allow some headroom around managing over the Christmas and New Year period. I think it's fair to say that the industrial action period get down to significant preparation and planning as ever. With one or two challenges around rotas and other factors, nevertheless went pretty well. And we did see continued operation pressure at a number of our sites, but certainly there were examples of the senior decision making resulting in better performance and better flow at most of our sites. At the end of industrial action, however, then the ongoing challenges around the availability of staffing and getting to the bed occupancy figure in the short period of time at the conclusion of industrial action and the Christmas period meant that there was quite a lot of focus on trying to get as many patients out as possible before Christmas. We got to circa 85%, not quite the 80% target, but nevertheless a good effort all round. So in terms of industrial action, it was well managed and patient harm was mitigated effectively in the circumstances, Chair.
And is there any further action planned?
Not at this moment in time, no.
Okay. Yeah.
John's just made an interesting comment about improvements as a result of senior involvement. Are there any new practices that we might adopt in a non-strike situation to gather the same improvements?
So I think it's been known for a long time that the more senior people
take better judgment calls
and improve performance by that clear decision making earlier on in the pathway. However, it is always going to be a challenge to get that level of seniority at the door 24/7. I think we need to accept that. But it is something that is being looked at. I think both locally and nationally, let's put it that way, because it is something that is obvious when the industrial action happens.
Yeah, and we should never waste a good crisis. If there are changes to be made that can be triggered by it, well, let's make them.
I think we get learning from it, don't we? And I think, you know, we're very appreciative of the fact that, you know, that you know, we flagged this as a concern and risk at this board. I think the minimal disruption that we kind of had and the efforts to maintain services through our busiest period, I think need to kind of be recognised. And
I think, you know, our light conversation about this is at risk of trivialising the actual challenge that it is to get that level of seniority at the door 24/7.
yeah, which is the crisis.
It is exceedingly complex. I don't want to underplay, you know, the challenge that it is.
And of course, there was additional costs incurred by providers as a result of that.
It's not cheap, is it? No.
So,
But when we come on to some of the performance stuff, I think there's a really good point there, which is around ED performance and around, because actually some of this is around what's the opportunity and the appetite to think creatively around some of this stuff. And so hold on to that. Time to sprint, Sean.
yeah, thank you, Chair. So there are 3 potential sprints going on at the instigation of NHS England, and the context for this is twofold. One, in relation to the national targets around elective and cancer, and as we've reported previously here, for our ICB and others across the country, generally speaking, those 2 areas are not being consistently hit, and there's a variety of reasons for that, but one of which is industrial action throughout the course of the year has compromised the ability of all providers to hit the referral to treatment target. So there is a series of sprints being set up for Q4 in order to maximise the impact on the national target. They're in 3 categories as set out in Teresa's note. One is around elective outpatients, second in relation to prioritising 52-week waits, and the third in relation to cancer. In terms of the first one, the elective sprints and focus on outpatients, there were a number of initial rules and prerequisites set out around that potentially could have compromised our providers from applying for that, and particularly in terms of ensuring that the sprint did not adversely impact on our financial position, because the key thing here is this balance between elective delivery and managing the financial context, particularly mindful of where we are as ICB and others. But there's been some relaxation around that in order to maximise that can participate in sprints. We're still waiting for the final outcome of that, but our providers across our patch have been given a positive green light around the likelihood of them receiving money for that, subject to confirmation. Of course, just to be clear, the NHS England is paying for that additional activity rather than this ICB, so there's an important distinction factor there. Secondly, in terms of the 52-week waits, there's been a number of trusts targeted for channeling of that resource, mindful of the current performance position, and for us, Hull, NLAC and York and Scarborough are eligible for that, and there's a number of conversations that are not yet concluded about the possibility of directing some additional resource into that space to help the 52-week wait position. And then on cancer, as we know, this is a challenged area for us, and there's likely, subject to confirmation, to be an additional £1 million allocated for York and Scarborough, NLAG and Huff to help support the delivery of approved cancer between now and the end of the financial year. That's to be confirmed, but it's looking more rather than less likely at this moment in time. So not all 3 aspects of those things are nailed down fully at this moment in time, but nevertheless, it's all looking very encouraging. And as soon as I know, I'll obviously share that detail with board members so they're cited on the latest position.
And those sprints kind of follow the areas of concern, which I think this board has flagged. So in some ways, they are the right areas. And I think the board has already expressed its concern around where we are. And I think, you know, our providers have shared those concerns as well.
There are some limitations in how much sprinting you can do simultaneously across those 3 of those aspects. And then obviously in one quarter of the year. But nevertheless, there's obviously a real focus to try and max that out.
Alison, did you want to?
That's actually what I was going to ask Sean around. That seems like a lot of intense activity at the same time. And it's one of those kind of things where everything becomes a priority. So unless it becomes a priority and also kind of really resource intensive. And so I guess my question is realistically running those sprints simultaneously, is that?
Yeah, it's a risk without a shadow of a doubt. And as things stand here, as I mentioned, we've not got all that fully concluded, but I think there is a recognition that that will need some dedicated capacity and resource in order to max out those, given the proximity of time within a very intense period of time. So yeah, you're absolutely right in flagging that issue. So it's not without risk.
You looked poised, Teresa.
No, sorry, I was just saying sort of, have you finished? Sure, because I think in sort of concluding, if you like, I think we'll hear this morning, both in this split board in more detail in the private board, the sort of the challenge that the ICB has got to the end of this financial year. So we are focusing quite a bit on next year, as you would expect, both in terms of the planning, the transition, the organisational change, but the performance piece that the sprints relate to in terms of planned care are only one element of a very challenged position for the ICB, both across performance, across finance, across quality and safety. So I just think we just need to have that well in our minds.
But I think we probably welcome the focus on those. But did you want to pick up the organisation change, or should we just leave that for Jane in the next item?
I think we can leave it for Jane in the next. There's not much to update, but I'll let Jane do.
Okay. Are there any other questions for Teresa based on the report? So we've had a really useful conversation there around mental health. We've had the conversation around the industrial action, the impact of that, but then also the conversation around the sprints, which I kind of think are focused on areas which I think have been flagged consistently through this board as well. So we welcome those sprints, but recognise the challenge that we are under at this point in time, and I think that will come through in your later presentations around reform in terms of the challenge we face as an ICB as we are almost halfway through January and into quarter four. Okay, so Jane, we're going to come to you for the consultation, the model ICB update. Just remembering there's a declared interest from anybody employed by the ICB, chair and the non-exec directors in this particular item.
There is very little to add than what you've already said in your update, Jason. So the consultation closed on the 9th of January, so last Friday. We're now going back through, as we committed to, all the responses that we've had through the consultation portal. We had already been doing, if you remember, the frequently asked questions every week. Some of those have been quite difficult because they're not really questions and therefore they're considered as part of the feedback in the consultation. We've committed to week commencing the 26th of January, having interpreted all of that and finalising our model so you can understand how tight this week and next week actually is. And Teresa, Jason and I had our first session yesterday going through some of that feedback. I think for our people, although the consultation is now closed, it creates another level of stress and anxiety waiting for what that final outcome is going to look like, which is why we are working so hard to try and get to that point to help our people understand what we think that looks like. The implementation phase that we then move into is going to be absolutely key, and working with our people around that implementation phase is going to definitely be key. We've had feedback, combined feedback from quite a lot of our unions as well that we're incorporating as part of that feedback, as well as from individuals, but also teams that have come together to put that feedback in. So incredibly helpful to help us to finalise the model. And I think we've said all along that the end model will look very different, we think, to what the proposal looked like based on that feedback. So I think there's very little more that I can say today until we've done that work.
And I think there's the parallel piece of work, isn't there, around? So there is a piece of work which we are starting, which comes next, which is around governance and organisational kind of structure. So Teresa and I will be picking up conversations with board members around that future kind of structure of the board, but also around the things that we put. So the structure at the moment is very much the staffing structure of the ICB. operationally, there are other things that we want to talk to people about, including within that as to how we engage with providers kind of moving forward, and actually how we make sure that we bridge everything as an ICB as a kind of a structure. So we're consulting we've consulted on the staff structure, but actually how the model operates, and those conversations we need to pick up alongside that. It's going to be really important in helping shape the final form of function. And we are about to press the button in the next couple of weeks on recruitment of 6 non-execs to sit around our new ICB board table. So thanks to the Remuneration Committee, which actually will enable us then to start to balance exec and non-exec roles and start to think about portfolios as how that fits within our operational model. So that's the plan moving forward.
Yeah, I just want to, so 2 things I want to say. Firstly, I think as from the board, we should say a big thank you to all our staff who have engaged fully. Which links to the second piece, which is actually the scale and the breadth of the comments, comments, suggestions, alternative scenarios, all of which, I mean, it's a very, very comprehensive response is what I would say, and there's a lot for us to work through. Some that really will and has already made us stop and think actually I need to find out a bit more about this. Some that is actually contradictory, so we've got different comments on the same thing but different perspectives, and some of that we'll have to take a view about. But as you said, Jane, and I said it from the outset, really, I really did expect that we would get commentary, suggestions and alternatives that would lead us to make changes to the original proposal. And I think that that's definitely going to be the case.
Yeah, and we've started that process, so that's very positive. So there's also an opportunity, I think, to pick this up in the private part of the meeting as well, I think. Right. So any other questions at this stage for Jane around where we're up to with that? Okay, superb. So we're going to move on to voice of lived experience. So Anya, how is your voice today? Anya is not here today because Anya has a bad throat and a cold. So Anya, are you okay to lead us into this one? It's a video, so you can keep your talking to a minimal if you want to.
Morning, Chair, and morning, everyone. Yes, I think my voice will just about hold up. I hope you can hear me okay.
Mm-hmm. Yes, you do sound better.
You sound better today.
I'm getting better. Yeah, thank you. So what I'd like to do, you've got the pack obviously as part of your board pack, so I'm not going to go through it verbatim. Hopefully you've had time to have a look at it. I will just talk through some of the headlines of this work, and then, as the Chair has just said, we've got a short film, and then I'll just pick up on some of the key learning points after the film, if that's okay. So this picks up on conversations that we've had at some of our recent board meetings. I think a few months ago we brought some insight around UEC attendances, and you may recall that the intelligence was showing that we actually across our patch have a fairly large number of what we would call non-urgent attendances, and in light of the move into the winter period and the known pressures we face, we developed a targeted outreach programme and campaign based on insight and data, particularly targeting neighbourhoods and communities where there is both a lower vaccine uptake and higher non-urgent UEC use, to really focus the resources where they have the greatest impact. And in terms of some of the headlines, as you can see from your pack, across the last few months, we have seen a really great uptake actually in terms of our flu vaccinations. So as of the 31st of December, we had a 2.1 increase overall against last year in terms of those flu vaccinations, and particularly in some of those key groups that we really wanted to see the vaccine increase. Of course, this isn't purely down to the activity that we've been delivering through this campaign. It is part of the activity that is being delivered across the system system. And you will remember from information that has been shared before, particularly some of our trusts have been doing a fantastic job around staff vaccinations, particularly Humber, FT and Harrogate. So this is part of a wider system approach, but still really positive flu vaccination uptake has been delivered. And in terms of the campaign itself, we've been really focused on using local faces and local voices. And as part of that outreach activity, we've spoken to more than 1,600 people about how to stay well this winter, and 450 children have learnt the importance of hand hygiene through our germ lab activity. And you'll see some of this on the film that I'm about to show. In your pack, it does say that 96 people through the community outreach activity have been supported to have their flu jab. We actually administered a further 25 at an additional pop-up that took place in the Priory Road Family Hub just last week. So that continues to increase through the remaining activity that we've got. So that just gives you the highlights of what's been achieved so far. But I will just ask Emma to play the film in a second, and then I'll come on to some of the key learning points. Thank you.
Thanks, Tanya. So are we good to go with the film, Emma? Here we go.
Not moving.
That one is that one.
What's that one? Not that one.
Oh.
Yeah, we did it there.
Okay, back to you, Anya.
Yeah, thanks, Emma. And that just gave you a flavour, and that was obviously particularly focused on the activity in the North Point Centre at Bransholme, which took place over half term. So again, just to pull out some of the key points from the pack that you've got, I think there's a number of really key learnings here. There was a big one for us actually in the sense of particularly the childhood vaccines, that you would automatically think that because it takes place in schools, that's almost ticking the box and it's getting directly to the children. But of course, as we found out and as came across on the film, there are, even in schools, there are a number of reasons why children are not having their vaccinations in schools. So having that additional option and taking it out into the community, putting it in a setting that feels a lot more familiar, a lot more welcoming and engaging, can build the confidence that just makes it super easy for people to do, is a key learning. And I think that leads into some of the work around the neighbourhood plans that we're developing. Likewise, in your pack, you will see we also had a session at the Islamic Centre in Scunthorpe, and a lot of the feedback there was around the importance, particularly in terms of engaging with our minoritised communities, of again delivering healthcare in a more trusted setting, with the endorsement, if you like, of relevant community leaders. So I think there's a lot of points there just to capture, particularly when we're thinking about neighbourhood health. And I think there's another key point, and I think the colleague from Vaccinations UK touched on this. It can actually be a lot more efficient as well. So notwithstanding the staff, if you like, resources, these community events cost less than £200 each to deliver. So they're really quite cheap to deliver, and that you can get a higher footfall than if you were having a more traditional clinic, as the colleague was saying. So I think there are lots of learnings for us to pick up in how we take this forward. But I hope that was just helpful to give you a flavour of that activity and the impact that it's had. And sorry I can't be with you in person today.
Yes, thankfully, some of them are vaccinated, so we wouldn't have picked up whatever illness you've got, you see. So that's a really positive outcome there, Anya.
And yeah, I've had mine, Chair. I've had mine.
Yes. Yeah. But the vaccination isn't going to mean you're not going to get it, is it? That's the bit.
Well, it might be something different.
Yeah.
That slightly dodgy science.
When you sit between two nurses, yeah, exactly. So
you comment on what you say.
Exactly. All my health myths, whatever my. So that's fantastic, Anya. So Bushra.
Anya did already touch on it. I am slightly bothered that a school had a trip on the day that a child was meant to be getting their vaccinations. And actually, I would like us to pick that apart a little bit and make sure that that's not because a school has failed to understand the importance of the flu vaccination and to really promote it within the school and to the parent community, or whether that's an issue with the commissioned provider, Vaccinations UK, just saying this is the date and we have no flex on that. Because actually, yes, there's a backup and the backup is great and probably does work for most people, but it's not going to work for everybody. And this is something we should be offering in schools to a captive audience who have already been prepped and primed.
As many opportunities as possible. Absolutely. Definitely. Simon.
Yeah, I mean, I don't sound like the sort of skeptic in the room, but I'm not sure that the £200 per pop-up clinic sounds right, because given how the pictures, how many staff there were standing around in
the balloons alone must.
If you include the staff's hourly rate in that, I think actually the cost of those clinics would be significantly more than £200. I can't believe that the entire staff cost included that, never mind the materials and all the rest of it. It could still be a very cost-effective way of delivering vaccines, and I think it certainly reaches people that traditional methods may not. So I think that's all good, but I think we just need to be careful about saying it costs £196 per clinic. That doesn't feel right to me. But and the only thing we also just need to be slightly careful of is that this is a 0.01% of the number of flu vaccines we're given in pop-up clinics in this. So it is it might be in the right place, but that is still a tiny number, and a very slight proportionate increase in the other methods of delivery, like things like the schools programme or those practices, for example, that are not quite delivering at the average of their local areas, would have a much larger, through the gearing effect, would have a much larger impact across the board, potentially than pop-up clinics. So I'm not against pop-up clinics. I think in particular areas, targeted things can be really good, as well as raising awareness. But we need to continue some of those other things that just nudging up the values in other areas, which I think we've done. If you compare us with our other areas within the region, our general figures are good. So I think it's a credit to everybody involved in this that we are reaching that. But we just need to be careful we don't become obsessed about one particular mode of delivery.
So sorry, just comment on that, because it's not either or, is it?
No.
I think that's the issue. It's complementary, and I think most importantly, needs to be targeted where we know that there are true gaps.
Yeah.
And I think that comes across quite strongly, because I was going to come to you in a moment, James, but I was going to come to the health inequalities angle, because I think this is significant with this as well. I think this is about the range of options that we have available, and actually the opportunity you might have through neighbourhood health, because experience tells me that coming through the door around a flu vaccination often then opens up an opportunity to do something else. So I think it's very much around having a range of different options. For some people will feel much more comfortable going into a medical establishment and getting a vaccine, whereas actually the opportunities we have, and actually that whole point I think is really well made, Bushra, around actually, if this is being delivered in schools, then there shouldn't really be a school trip on that same day when that's kind of happening, because there's a cohort of people who would be willing to have a vaccine who are prevented from doing so. So I do think, Anya, this has been a fantastic kind of piece of work. I do think it's been really kind of creative. It builds on principles of neighbourhood health, which are about maximising community assets. What more could we do? And actually, in some ways, whilst I appreciate the point about cost, actually, I think in some ways this is about the outcome is actually a group of people who wouldn't necessarily be vaccinated. And I think thinking around the concerns we had around this table, particularly around the impact of flu on a really precarious kind of UEC kind of position, the impact on primary care, actually developing a range of options proactively that are targeted is exactly kind of where we need to be in terms of thinking around a response which feels much broader than what we've kind of provided in the past. So I'm going to come to you anyway, James, because the point I was going to make was that when we look at the areas of low take-up of vaccines, in my head, that equates to our most deprived populations. So we're looking at the health inequalities kind of angle on this. So that was what I was going to throw at you as from that health inequalities point of view. But I guess there's probably something else as vaccination lead that you wanted to.
It was to pick up on, so the reason for that. On Bush's point, and I'll pick up a conversation with the NHS England, who are the commissioners of Vaccination UK, because you're absolutely right. School trips are probably booked a reasonable distance in advance. Our Vaccination UK ensuring that they're coordinating programs to get the maximum opportunity, if not uptake. If you're not there, you have no opportunity. So, coming back to the inequality. I'm sorry. So I think I agree with Simon that and Teresa, there isn't one. This isn't an all or nothing approach. That there are a number of different approaches. And I think, and I appreciate it was different because the population was incredibly scared at the time. But if you think back to the experiences around COVID and the COVID vaccination program, there's a cohort of people who are looking forward regardless. We don't need to worry too much about them. We just need to make services accessible. But there's going to be a population who need additional support. And now, whether that's about talking to existing providers, and I agree with Simon, the giving effect is much bigger than simply popping up at a population level. But that still may not support us with those small groups, the smaller cohorts who would benefit, who are, for whatever reason, not able to access. Now, whether that's due to geography, transport, trust. There's a whole set of conversations around that. And I agree. I think this is part of, I guess, for the night of the future, what the neighbourhood models could be looking at delivering and working collaboratively and who knows who could deliver it, but there's lots of organisations out there who do. General practice is the biggest, I suspect, by far. Community pharmacies, we've got Vaccination UK in our area, but there are other organisations as well. So I agree. I think this is part of the ecosystem. I think it fundamentally sits in that neighbourhood conversation.
Definitely. Mark.
Yeah, just a comment and a question for Anya. First of all, I think this is really good in the context that we've used population health data and insight to target interactions on particular communities where there are needs. And that for me feels very much like what we ought to be doing going forward around many things we do. I guess the question, which links back to some of the other points, is the actual staff who were there doing the vaccinating and other stuff, do they work for the ICB or do they work for someone else? Or I didn't quite understand that bit.
I think they were Vaccination UK staff, weren't they?
It was Vaccination UK staff that administered the actual vaccines, but then it was ICB staff that supported the delivery of the events and had many of the conversations and delivered the winter wellness packs, etc. So I guess it's back to Simon's point, and apologies, I thought I said that doesn't include the staff costs, but there is something about, it's Jason's point as well, in terms of having the richness of the wider conversations when you're having some of these types of pop-ups, if you like, delivers value in itself, but also some of that can be delivered by non-clinical, non-medical staff as well, which obviously is much more cost effective. So I wasn't suggesting that the £200 was inclusive of all the staff costs. However, it was inclusive of the balloon costs, just to confirm that with you.
Yes.
But agreeing with Teresa's point, absolutely, this is complementary and supplementary in a targeted way. There wasn't the suggestion that this would be, the one-trick pony, if you like.
Yeah. Okay. So huge thanks, Anya, to everybody who was kind of involved in this. And I kind of think very much that agility we had in developing a campaign that was kind of very seasonally focused, based on the concern we have, and actually the impact of that, not only in terms of the people who received the vaccines, and I love the bit about him getting his sticker. Yes, great. Yeah, that happened more often. I go to the doctors more often. But also in terms of actually some of this and that real focusing on local people in terms of the campaign as well, because actually the strongest bit I think I found when I worked in the mod sector was the word of mouth of Betty down the street saying, I'm going to go and take my kids for a vaccine, and then the influence that Betty then has on a community that might be reluctant or hesitant. You cannot underestimate, the power of communities and community leaders, and I think that's really strong. Michelle.
Yeah, first of all, great, and anything like this is good because we're the sum of our parts, aren't we? And we need to do it in different ways. I think that's really good. It might be useful to maybe know when these things are happening because you can always coordinate it with other aspects as well. So it's not just about the vaccination. We can link in.
What could you do?
So, for example, we could do some of our pop-up work around alcohol, etc. So you're actually ticking a few because that builds in your neighbourhood thing. So there's just a word next time if we are doing anything around this pop-up, then let us know because we might not be able to do, but if we can, we'll be there and do some of the other work that we do in relationship to that health and wellness. Because we can do a lot of quick MOTs and things with people in general. So just let us know. We can't always promise, but we'll try our best.
No, I think it does. I think very much. I think Hull very much kind of through the Housing Qualities Funding, we're looking at the idea of these pop-up health fairs that actually brought together a range of different services in a community setting, and the opportunity to do blood pressure checks and wellbeing checks and alcohol advice as well as kind of vaccinations was really well received by communities who wouldn't necessarily have gone to an NHS event but went to a community that happens to have the NHS at it. And I think there's a whole model around the engagement and around how we deliver stuff, which I think is quite exciting around neighbourhood health. So thank you for that, Anya. Amanda.
Very quick question, Anya. It was the data around pregnant women in York having a low vaccination rate, which is probably driven by some interesting things. Have we had any feedback on it, Anya, because actually those pregnant women should be booked in and
a priority. Yeah.
in the maternity services at
absolutely.
York. So I'm just, we can pick it up out of here, but I just wondered if you had any feedback on that piece of data.
I haven't got anything directly, Amanda, but happy to pick it up out with us.
I think that would be helpful, wouldn't it? I think, and I think some of this is around some of the what I've always around the vaccine stuff is the myths around vaccinations, and actually sometimes it's the conversation in a really empowering way that enables people to realise what they believed for 50 years was wrong. Okay, super. Thank you, Maggie. Chance to rest your voice until later. Super. Thank you for that. So we're going to move on to the integrated performance, quality, workforce and finance reports. And I think we're going to be joined by Simon Worthington, who's the chair of the Finance, Contracting and Performance Committee. I've got the wrong order, but it's those words in a different way, isn't it? There, Des. Okay. So we're going to take this in the usual way. So you've got all the information kind of in front of you. We will pick up more detail on this in part 2 as well. So I think very much this is kind of the headline kind of position we are. I think you've already teased us a little bit, Sean, in terms of the current state of play. So I think there should be no surprises around this kind of table. And I'm proposing that we kind of take it in the order. So if we start with performance first, we'll come on to the money and then pick up the quality and we'll pick up the workforce bits as well. But if you set the scene for the performance bit, and I'm sensing already this isn't an easy read.
Without teasing, that's probably a fair comment. Yeah. Thank you, Chair. So I think this is the report in 8. So you've got data here for urgent care for November and plan care for October. The latest data comes out later this week for November and December, respectively. So there is that time lag before Stuart regularly points that out to me, and we can only work with what we've got. But I will mention some latest positions on throughout in terms of the commentary. So I think, as mentioned, UEC further challenge during November is when we started to see the impact of the flu increase that compromised flow and resulting impact in terms of ghost beds and so on. So that was a material consideration, not unique to our patch. And that's continued to be a material factor during December and the early part of January, amongst other things. For plan care, as we touched on earlier, there continue to be some challenges. We've got some providers that are ahead of plan on referral to treatment, notably York and Scarborough and Harrogate, and there's less so. And we continue to experience some challenges around 52-week waits and 65-week waits. That latter target still represents a stubborn rump of patients that we need to work through to get a treatment date for them, to get that down to 0, consistent with the national ask, but continued work in progress on that. Diagnostics and cancer continue to be challenges for us. There is some slight improvement in those 2 areas for the latest data here, but not material, and certainly away from the plans that were set at the beginning of the year. In relation to primary care, we continue to deliver against the 14-day booking rule in relation to appointments. And certainly in looking at that data in more detail, we have offered more appointments throughout the course of the year than previously. And so that's really encouraging that we managed to sustain that. And likewise, in terms of dental activity, we've met the planned contracted level for September, and the overall trend is showing variation or improving nature. So again, that's encouraging in terms of improving dental access and maximising the dental ring fence money that we've got, which we aim to try and continue to do so between now and the end of the financial year. And mental health services continues to be an area of positive performance, with one exception, and that relates to the position in relation to target for inpatient stays for autistic adults. Again, a national target around that is a challenge for us at this point in time. So in terms of the performance position, all those areas remain during December and January constant areas of focus. I mentioned about the sprints, and we're waiting confirmation around that. And clearly UEC will come on to more detail as part of the winter update, etc. Chair. But with that, if I can pass over to Des and then Amanda respectively.
So any questions, first of all, in terms of performance? So I kind of think there's no surprises in there based on where we were last month and the month before that. I think you've covered off the slightly improved kind of performance due to the resident doctor's action in terms of some of the stuff around acute, but quite a difficult position to be in terms of outcomes and continuous kind of sustained pressure across the system, with the exception of mental health, which is progressing very, very well in terms of our mental health kind of performance. Any questions for Sean on that? You know, have a chance to speak. And also, and very much, I think, picking up some of those things around cancer and diagnostics, which have been deep dive conversations at this board, where I kind of think, yeah, there is, you know, the board has an understanding of both of those areas. Actually, I think the board was quite clear that they were concerned about the position and were interested in whether or not there was progress and improvement in terms of cancer and diagnostics. Okay, so no questions for Sean at this point. So let's move on to the money, Des.
Thank you, Chair. So just to note that the finance is reported in the pack on month 8 and not month 9 as indicated on the agenda. Month 9 is yet to be submitted. So in terms of the month 8 position, firstly, the ICB was very marginally off plan at month 8, but still forecasting to be in line with the plan at the end of the year. But just to note in the commentary there that we continue to see significant pressure in the independent sector, both across the acute portfolio and the mental health portfolio, mental health being largely around the ADHD referrals, as we've discussed earlier, and with the acute portfolio, that is in part because of the risk share arrangement, additional efficiencies that we put in there, but also a lot of new entrants into the market, things like weight loss drugs and other elements that were not in our plan this year. In terms of our providers posted a £38 million deficit. Within that, mental health services is a small £3 million surplus, but the bulk of that deficit is sitting with our acute, all of the deficit is sitting with our acute providers. That number puts us £22 million of plan year to date, month 8. And as we mentioned earlier in the BAF discussion, at month 8, NHSE indicated that month 9 would be the month where providers were allowed, or providers, ICBs were allowed to change their forecast. So during the year, we're not permitted to change our forecast until NHSE tells us we are allowed to. They came to work to us in month 8 saying we could do so in month 9. All of our acute providers signalled at that point that they would be pushing their forecast out, which is what we're expecting to see in month 9. And that was the driver for us moving the BAF score, because whilst we've been signalling it is a risk continually during the year, we've put various mitigations and interventions in place. As at month 8, it was considered that that position would not be clawed back to the end of the year. So where we see that bearing out is in, I just jumped slightly in the report, the unmitigated risk section. So last month we've seen a small improvement of that, and it reduced to 72 million. However, the provider version of that swung right up to 74 million from their 62 million. So they achieved the position right first. So the whole system risk went up to 90 million pounds in month 8, which was a sort of precursor, I guess, to the worsening of the forecast and the intention to move those forecasts adversely in month 9. The ICB unmitigated risk position within that has also slightly improved. We are holding our forecast to the end of the year. It is very tight, but at the moment we continue with our regime of very, very tight financial management and holding off anything that is, post scrutiny of anything that is being agreed to go out at the moment. So that's where we stand with the ICB. Just in terms of drivers for the provider plans, two significant things on your sheet here is firstly, as of month 8, providers were £28 million off plan. So of the £22 million adverse variance, £28 million is because the efficiencies haven't been delivered. Obviously, there are some mitigations within that, but it further bears out in £35 million adverse variance on the pay lines as well. Now, some of that is mitigated in the I&E against income, so though you can't add those two numbers together and come up with a bigger one, but it all sort of indicates to the issues that they have both in managing their pay, which I think we'll pick up in the workforce numbers, and also not delivering the efficiencies that they need to deliver. And that will in part be because of pressures and in part because of the way that they phase those plans and the back ending of them, which we've been signalling as a risk in our finance committee for some time. Those were all of the key points I was going to pick up at this stage. And as I said, we are expecting that month 9 will look a lot worse because the forecasts will move, and we think that number's around 90 million. But
we always anticipated that it would be trickier backloading the plan where we are now, don't we? Simon, welcome. So we've already approved your increase in risk, by the way, when we did the BAF. So we've done that one. Is there anything, Simon, you wanted to kind of throw in based on what Des has kind of said in terms of the finance kind of position that we find ourselves in?
Well, not to add to what Des has said, but I think it's important for the board to know that the committee is not, the finance committee is not surprised by the deterioration in the acute sector, particularly because of the assurance work we asked for. So it's fairly obvious that was going to happen. And I suppose the question for the system is, in knowing that was going to happen, what are we doing about it? And obviously, this deteriorating position will have severe implications for next year's financial plan within the providers. Moving into a territory where different levels of intervention will start to happen, I think.
Yes, I think that's the reality of where we are now. I think that's really well articulated. Okay, any questions?
Should I just say a little bit about interventions? Actually, I should have probably picked that up.
Yeah, so that would be helpful.
So there have been a series of interventions between the ICB and region because of the changing in regime. We've sort of split out what we needed to look at, but there's been a series of returns that have been asked for around the governance, board assurance framework. There's an HFMA checklist, a well-led checklist. All of those have been asked for, and those will go through an external review, which we're just going to put them through an external review. There's been a balance sheet review on all of the balance sheet, and some queries have gone back to providers on that as well. And then York and Scarborough have requested an external intervention from an external company. So further continuation of the work that we initiated earlier this year through the Finance Committee. So we're on with that. I think there will be further scrutiny of figures. So with the changing forecast protocol, almost business case had to be written by each of the providers that have gone up to really senior management and NHSE, and we're just waiting further feedback on that and whether there's any other follow-up next steps off of the back of that. So there's a lot of intervention work. It is not the case that everybody's gone, oh, well, yes, it's very terrible. Yes, there is a lot of intervention work happening in the background. Oh, and the double lock, I don't know how I forgot that because it's an immense amount of additional work for us in the ICB, but actually all the provider expenditure goes through another rung of approval once it's gone through their systems, and anything over 50k and any non-clinical vacancy requests are coming through to the ICB for second round of approval, and as of January we join that as well, so they are also another line of so it's making it more and more difficult for spending money.
Could I just add, sorry, just for clarity, the piece of work that York and Scarborough commissioned building on the balance sheet review, it also includes Harrogate, so Harrogate's going through.
Right. Sorry, I thought I said that, but yes, it's Harrogate and York and Scarborough.
Yeah, so there's a set of actions, I think this is what Simon was kind of pointing out, there's a set of actions that kind of follow on from the understanding of the position that isn't just a case about acknowledging the position, and I kind of think whilst welcoming the principle of the double lock, I think we just need to be careful that stuff doesn't get held up because we have got different hoops to kind of run through. There is something around efficiencies about being able to make the right decisions, isn't it? But it's understanding the reason why at this point
it's
double lock
non-clinical expenditure. So just to assurance, anything that needs to make the providers work for patients, that's untouched by this. This is around discretionary and non-clinical.
Okay, so we've got the performance position, we've got the finance position. There's a bit of a shining light in terms of mental health, but the rest of it's pretty bleak. Moving on to quality, Amanda. So I suppose what the board is hearing is that performance is not where we'd want it to be. The money feels though it's not. So what is the impact in terms of quality in that triangulation?
Yeah, I'll just walk you through a few key things if that's all right. So I'm going to start where Sean started in UEC. Clearly, the position that Sean described has significant quality impacts and what we've seen over the last couple of months really is particularly around the increasing number of patients who are being cared for in our acute provider hospitals, in corridors. I've had a recent round of conversations with chief nurses. We are going to do some urgent work in the next 2 to 3 weeks with the chief nurses of the acute providers around learning from that. We've seen significant numbers of patients, I would say. Clearly, that has an impact on crowding in our emergency departments. I don't think our emergency department colleagues would disagree with that, and the impact that has then on things like time to be seen. So we're doing a review of incidents through our patient safety team, and that will be working its way through and up to give assurance to quality committee. Alongside that, and I have flagged this, is the impact on infection prevention control, because once we start to see crowding in the emergency department and corridor care, and clearly an inability to move patients through and into the appropriate environments, we are seeing an increase then, and have seen over the winter months, of both flu and norovirus. And alongside that is clearly the ongoing work that we need to do around adherence to IPC. So in terms of UEC, it would be remiss, Sean, I think, of me not to mention the impact, of course, on our ambulance providers, that when we start to see a drift in ambulance handover times, that can have in their response times to calls. If I go on to elective, I think the triangulation of that is probably we need to do some further work in terms of impact of elective. We know that our organisations have got scrutiny of long waits, particularly in cancer, and that to date we are not seeing harm coming through those reviews. But I think as an ICB, we need to see more assurance around some of the other elective services, particularly around ophthalmology, where sometimes you can see incidents occurring when we've got long waits. So we'll pick that up. And then the other bit for me, is to flag for children, is the work that I'm just starting to pick up with Sean's team around ADHD and autism, and the waiting times and the impact that's having. So we've picked that up for our local authority colleagues to give assurance that we are going to have some focus work on that. And alongside that is the outcomes of our SEND inspections, and obviously working again closely with local authority colleagues and our DCSs on making sure that the actions that we've got as an ICB are being enacted, and we've got good oversight of those. And then I will just end on maternity, because I think that the maternity services clearly that we've got in our patch, we've got Hull that had their 2023 inspection that had an inadequate, unsafe and well-led, and York clearly also had an inadequate, unsafe and well-led. And I think it's just to acknowledge the work that's been going on over the last couple of years in those organisations to demonstrate improvement in maternity outcomes. There's still some work to do, but certainly I think the trajectory is one of improvement. Clearly got 2 Section 31 notices, both in York and in Hull, and there is an expectation that both of those organisations will be able to meet the requirements of the Section 31 notices.
Thank you. I think it's important to recognise really positive progress. I kind of think, it's equally important to say that despite the challenges, we are doing some stuff that actually is really highly looking at making up a difference. Just a quick clarification question. So in terms of, so I'm now seeing stuff, Sean, on a regular basis around bed occupancy. You know, you and I have a conversation almost all the time about bed occupancy. For patients who are being looked after on corridors, is that captured in bed occupancy, or is that something different?
It's captured in a separate report around test bases.
Because it would be.
So sorry, Jason, because they're not formally admitted at that stage, are they? So they're not in the bed occupancy.
I think it would be useful, probably based on what you're saying, Amanda, if we could probably at some point just make sure that we understand the numbers we're talking about in terms of that, because It's the significance of that and just ensuring that there's the total oversight that we see, I think, and it links back to your whole point about risk and managing risk. Simon.
I was going to support that. I was going to ask the question that similar to one that just been your implied question there, that I think given how important we've said corridor care is, or they're getting rid of corridor care as an indicator of poor experience and likely poor outcomes on IPC, to actually have it really visible as one of our significant, and I know that there's a difference between quality and performance, but whether it is a quality indicator or performance indicator, but it needs to be really visible in the reports, doesn't it? And I know it's really difficult, and I know it will be exposing, but it gives us a sense of the scale of it on a day-by-day basis. Are we talking about 5 patients per unit? Are we talking about 50 patients per unit having those sorts of experience? And hopefully watching that come down over time will be really gratifying.
And can I just so I think it's a safety indicator, and I think we need to link it really closely to actually just fundamental safety. So yeah, the idea is that and there's new guidance out, but really the narrative should be this is not acceptable.
Yeah, I'm really keen that however uncomfortable and difficult it is, that we get a real position, that we understand what it's like from the point of view of somebody who is accessing services today. What is the experience they have, and actually is that the best outcome, and actually what are the risks that we are managing? And I think holding back to that one person who at the moment is waiting for an ambulance today somewhere in our system, who is going to end up in a hospital, that actually we understand what the experience is like, because actually that's fundamentally brings us back to the reason why we're around this table. Michelle.
Yeah, thanks. It's great. I mean, it's good to see the quality piece, and I think actually personally, I think we should start with it rather than get into the actual metrics and then the finance personally, because then I think that sets the scene for what we're going to talk about in relationship to the others. But I'll just throw that out there. I think on the corridor care or beds away from the main areas or whatever we're going to call that, I think for me it's about from an ICB role trying to understand a bit more around the quality indications and what's happening of that, not through the patient expectation, but length of time, what happened then, any adverse reactions, etc. And it's not for us to do the provider job, because we're all doing really great work on that. I'll find the best. I need to understand a bit more from an ICB point of view, and is there anything else that we can assist from an assurance, and just to play from the ADHD, because we've got that many people now, I think personally involved with the ADHD stuff, which is too complicated, and I've lost completely any community, lost what we're doing in relationship to it. We've given lots of solutions to it, and in fact I did think after the regional meeting on Monday and the meeting on Friday that we'd got a way forward. So please, if you ever, we've got somebody that's looking at the quality aspects. We've got somebody that's trying to look at the waiting list, because we don't know. Well, the ICB, for example, doesn't know who's gone to another provider, etc. So we're trying to do something on that. So let's not all reinvent the wheel. So happy to stop doing it, but let's just make sure we have a bit of a coordinated effect, because at the moment we're putting a lot of resource in and not getting very much out. And I think we're not making any progress at all, to be honest. In fact, it's just gone backwards. So, and I'm not just saying that with the provider hat on that. I'm saying that from an ICB board member point of view.
I would really echo that. I kind of think if we can do some stuff once that's useful to everybody, that actually maximises people's time and is very much kind of solution focused.
We're losing so much ground on other ICBs now, because I know I'm advising other ICBs. We're losing so much ground on what we're doing. So I just think we just need to maybe just take a bit of stock, and maybe the ICB board needs to take a bit more.
No, it's useful. It's useful. Robert England, I suppose, just for completeness, I suppose we need to record in terms of this item the interest of our providers around the table in terms of this. So we'll just record that, but it doesn't stop anybody contributing, because your perspective on this, I think, is really important. Lynn.
Thank you, Jason. So I would agree. I think there's real value in collecting the data on corridor care. It's not something anyone aspires to and certainly wants to reduce and eliminate over time. But I think we need to be careful what metrics we use and how we interpret those. And there's got to be some consistency across all providers. What I'm quite excited about is this could give us the lens to really have a meaningful debate at a system level. And I know that's something Teresa's quite keen that we follow up on. So when you get corridor care, it's often for a variety of reasons. As you know, it's not just one part of the system that's having a problem. Stripping all of that back, looking at the data over a time series would enable us to say, So what do we need to do collectively to reduce that and give the patient the better experience? And I think that's how I think that would be a great way to approach it, rather than this is about the collection of numbers and then it's about, performance managing that to within an inch of its life, because it doesn't change the experience or result in a removal of the problem. So if we do it in a positive way, I think it's really, really helpful.
I would totally agree. I think everything we do should have a purpose, and everything we do, there should be an action that comes from it, because actually stuff is interesting but not useful. And actually we're at a point now where actually the opportunity we have as a group of providers, partners, commissioners, stakeholders, then think about, if this makes us uncomfortable, we then have to do something about it. And I think that's exactly kind of where we are. Is there anything from we want to workforce? So sorry to leave you last, James. So I'm hoping for good news.
There are some bits of good news, but the continuing dilemma of the workforce delivery against whole time equivalents versus the pay bill, which Des has already referenced. So, but if I talk about the whole time equivalents for all the staff groups, so that's agency, bank and substantive, we're 46 above plan this month compared to 306 last month. So that's a significant shift, and certainly for the agency, the target was 30% reduction for this year, and at this month we've hit that 30% reduction. So that tells you the amount of work that's going on in providers around that, similar to last year. So there is some good news. The substantive is still above plan, 165 above plan. There's some positive reasons for why some of it is above plan. So when you look at whole time equivalents in isolation, it's not a really bad news story, although obviously everything's backloaded as well. So this last quarter is going to be really challenging. We've got the ongoing triangulation work, which is trying to get under the skin of why the whole time equivalents are doing relatively well, but then your pay bill is so exceptionally high. And we've got a further pay bill and agency management committee meeting next week where we'll go into that in a bit more detail. And if you remember, we had actions that we'd all agreed that we would take to try and mirror what you're already doing, Michelle, at Humber, around that. So we'll see how that's going when we meet in January.
Okay, so we've triangulated those four things to kind of give us that performance report. We can pick this up in more detail in our second part of our meeting. I'm conscious, Sean, that we probably bled into the winter position through that conversation. So we've already kind of picked up some of the winter stuff through the updates that you kind of gave on the River Doctors and the sprint. So I'm conscious we have a winter plan that the board's kind of signed off, a winter plan that anticipated that there would be some particular issues we needed to address, although I think the board made the point at the time that in some ways this has been an ongoing situation. So winter was just an interesting concept, but actually whilst we expected to spike, there were some endemic issues that had been there around, and I think we touched on them in that kind of performance report. So particularly in terms of winter, anything that you were wanting to share with us?
Yeah, I think you touched on the main issues there, and obviously Amanda cited the patient safety and quality challenge, particularly around corridor care. We can come back conversation later.
Can we look at corridor care, or however we want to term it? Can we look at that at the next meeting? So can we have a particular focus on that? And I'm interested in the quality aspects and the numbers and around the board's view on where we are in terms of, I think that would be helpful to pick that up as a separate item rather than just as part of a wide report. Yeah. We can work on that. That would be helpful.
Yeah, I think just to say in terms of winter, obviously, without repeating a number of things that you cited there were a number of practical steps taken following last law conversation with Tracy and her dad's colleagues in terms of interface with social care ahead of the Christmas period. The 6-point plan that we developed and agreed across all parts of the system. And inevitably the Christmas and New Year period was challenging. 2 very long bank holidays in there, discharge of flow inevitably became compromised. And the first week in January, as is always the case, was very, very challenging, I think it's fair to say. And the numbers, patients presenting, the challenges around flow and flu and ambulance handovers were the most challenging, I think it's fair to say. Having said that, things are slightly calmer this week, relatively speaking, but there are other providers across the country that have declared incidents in the last few days, so we haven't been in that space, in contrast to other parts of the country have been citing similar reasons as the reason for declaring critical incidents. And I think the other thing I'd just cite briefly is going back to the vaccination point in the video shared earlier. The latest top 5 providers across the country feature Harrogate as number 1 on that list at 67% of its staff vaccinated, and Humber FT third on that list at 65.8%. So I think the positivity around the vaccination position for those 2 providers and the efforts, to be fair, for others has been significant. So really positive effort around vaccinating our staff.
Okay. Who is that?
Yeah, so just a couple of words from me, really, in terms of we're still in winter. I don't want to give anybody the impression that Christmas and New Year is the only thing we need to worry about in terms of winter. And you know, you can look at it and say, you know, it's better than we were 2 years ago. And yes, it's better than we were 2 years ago, but it's not where we need to be. And the experience of patients, as we've just talked about, is definitely not where we would want to be. And there's a lot more work still to do. But on the fact that we're not out of winter, there's obviously the cold weather. Now we're going to see a bit of an improvement in the weather and then perhaps a decline again. So we know that that has an impact on ED attendances. But I just wonder, James, I just wonder in terms of the flu, we had that peak. There's expectation, is there, of that a second
wave?
Honestly, don't know.
Okay,
but I can find out from
back to this later. I think we do tend to see a post-Christmas. Seth and Stuart were discussing this. The young ones in people's families tend to have a habit of oversharing, and therefore that affects
it's the schools.
It's certainly not likely to see that. And I think the other thing, the weather has an immediate impact. So we have seen slips and trips as a causal factor of people attending more. And you do see an increase in respiratory a few days after the actual cold passing. So, but obviously, the roller coaster around the weather does have a material impact in terms of demand, particularly amongst the frail elderly.
Yeah. I think it's a real positive there. I really welcome, the conversation, the cross conversation, Tracy, with Director of Social Services and Social Care, because I kind of think there is something around the approach around winter has to be a system approach around that. So I kind of think whatever we do with the badge of winter also becomes useful without the badge of winter as well. Because I kind of think there is something here around winter has given us a focus, but actually it's a position that this board has not been comfortable with for probably most of the year. So I kind of think how we build that and how we have the opportunity in the future, through the New York ICB and our strategic commissioning role, to think around UEC and that interface with primary care in particular. I'm thinking Busher assignment in terms of people are going somewhere and actually it's probably not the right place, but actually that investment in neighbourhood health provides us with an opportunity to start to think around prioritising who needs to be where within our system. So thank you for that, Sean. So and of course winter is not yet over. I woke up this morning and thought I'm even colder today than I was yesterday. Okay, any other questions for Sean? This is the Sean show this morning, isn't it? There's a lot of Sean. So we're going to move on to the emergency preparedness, resilience and response for standards. So we're going to note the contents of the report, and we're going to improve the self-assessment and the associated action plan. There's a lot of self-assessments going on at the moment, isn't there?
Yeah, there is. This is in fact, this just to be absolutely good. This is, in contrast to much else that I bring here, this is good news, Chair. Yeah.
Good. I'm pleased about this. I'm pleased about this.
So that being noted, minuted effectively. So
the positivity in the meeting relates to our emergency preparedness, resilience, and response.
That's correct. That's right. So just to put this into context, this is an annual requirement of the ICB as a statutory Cat 1 responder under the EPR legal requirements, and that's both as an organisation and as a system coordinator in terms of coordinating the response of health partners in the event that an incident is declared and needs to be responded to. And this is the annual process of NHS England of having a set of very detailed and specific and thorough core standards that we have to work through and assess ourselves every single year. And this also equally applies to providers as well. So we have a twin role around doing it for ourselves, and we have a role in basically discharging oversight role provided and their self-assessment. So we've done both of that, and this is the conclusion of that. And in particular, reflects back on the position around our compliance with those core standards. Now, just to be absolutely clear here, the compliance rating and judgments are artificially high in terms of this assessment. So last, in fact, to 2023, we were 32% and deemed to be not compliant. In 2024, we were 60% and deemed to be not compliant. In 2025, pleased to note that our position has improved. So 79% were deemed to be partially compliant. That's because the compliance threshold is very high. And so that reflects a significant improvement. And I think the other thing just to point out is that this is at a time of which, during the majority of the year and only relatively recently confirmed, is that this EPR responsibility for the ICB was under much uncertainty around what will actually continue into next year. So the staff working in this area and coordinating this have been operating within that cloud of uncertainty, which has only relatively recently now been bestowed upon us for the subsequent years. So a really positive position. There inevitably are areas of improvement around training, around exercising, and associated aspects which are set out in the report, Chair, but happy to take any questions.
Okay, and the confirmation is this remains with us in the ICB.
It does indeed, yeah.
So that solves that uncertainty. So we'll be looking at this a similar report in
contrary to what was initially said.
Yeah, which is I suppose I can understand the anxiety that's caused. I mean, this lists the incidents that have happened during the year, which is interesting.
Extensive, yeah.
Exercises.
And the exercises, the tests. I always kind of think with this stuff, if you were 100% perfect, there's a problem. So I kind of think there is a plan and a set of actions, which I think we are able to do.
Just to build on Sean's comment about the cloud that staff like the staff groups have been under, but it's a tiny team. And you see the scale of the work that they've been doing. It is a tiny team. And I think we just need to note that, it is a tiny and exceedingly busy team.
Yeah. Yeah. And we are able to say we're compliant. So,
Bills of preparedness for emergencies. What's our responsibility if war breaks out? So we're in a pretty miserable international setup. Does that come into this?
That's a scenario. I'm not sure that's been tested.
We have military barracks. We have funny golf ball things in Harry. There are plenty of sites that might be targets.
Yeah.
Well,
I think mindful of the small team that Teresa showed. I don't think we're primarily responsible for that, just to be absolutely clear. But we will have a role.
I'm in the medical.
We'll have a role around coordinating that in such circumstances. Absolutely.
Through this kind of thing. Yeah. And so the follow up is why have we got a small team at the moment? Because the world is getting riskier all the time.
Because the team is about the coordination, and actually what then happens is an expertise, and then it's about the mobilization stuff that kind of is overseen by the team. So these aren't the people doing all the stuff. This is about ensuring that we are doing the right things and we are fulfilling our duties in terms of emergency kind of response. So I kind of think it's very much that partnership approach, isn't it, towards the NHS bit?
I think just to clarify, they're not the team providing the full EPRR response, as in
everybody.
That's why we have on-call systems and all the rest of it. So everybody's involved in the response. They are the team in the background providing the expertise, the policies, the commissioning pieces, absolutely, and making sure that we get our training and all the rest of it. So they are very busy, but then they're not the totality of the emergency response, is what I'm trying to say.
Yeah, it's part of a much bigger picture, isn't it, Jane?
Couple of things. It's really good to see this actually all in one place. But a couple of things on my mind is we're a much smaller organisation going into next year, but we're retaining the responsibility for all of the on-call, and that's going to be relatively challenging, I think, Sean, when we get into the detail of that, isn't it? And then the continual challenge for the team of trying to get everybody trained. You can see in the table that's in the paper here how challenging that actually is. And we've talked, I know, on a number of occasions about how we do something different about that, because in some instances, like the joint decision making awareness, for example, none of the strategic commanders, of which I'm one, have done that training. So I don't know what we can do outside of here, working with the team to look at how we can improve that. We've got the same challenges in other arenas, not just this one, but it's really critical, I think, particularly if we've got less people on call and get more experience. We'll lose possibly some of the really experienced on-call people. So it's just a flag, really.
Chair, can I just come back on that? James makes two really important points there. I think there is a significant risk about us retaining this function in terms of our on-call capability and capacity, both in terms of numbers and the skill set that we've built up. But one of the reasons why our training compliance on this, despite best efforts, has been tested is twofold. One, because at the signal at the beginning of the year that we were to be responsible for this from April 26 onwards, and the capacity of our organisation has been stretched in working through org change and other factors. So therefore, in balancing a number of things off, difficult that is, this has not necessarily been the top priority. So the reality of where we are and where we're going to be, and it does need some careful work.
So can I just come in on Jane's point, because it is a really, really important point. And I'm sure we'll get into this conversation in other guises. But in respect of EPRR and the on-call, my expectation is that we will reduce the on-call commitment because it is solely for EPRR and not for the system response or emergency pressures, etc. that we have now. There is a move, obviously, for us to continue with the arrangements that we currently have, with a suggestion for us to maintain the SCC, etc. We will not have the workforce to respond and to cover that level of on-call. And it will be part of our ongoing dialogue with region in terms of the SCC and the future oversight.
Yeah, I think we need to make sure that we're recording those risks somewhere as well. So we need to be aware of those risks, because it sounds as though we need to think about the actions to mitigate the risk. But I think there is a significant risk that you've flagged through that. I think it's the right risk to flag. We just need to make sure they're recorded somewhere. So are people happy to take that report, know the contents, and approve the self-assessment? It's a requirement that this comes through the board. People happy with that? Yeah, thank you. So we're going to move on to the insights report, which are the updates from our key committees, flagging any issues. It kind of gives you an idea of what those committees have been talking about. So we will take them as read, unless there's a particular issue that's kind of being flagged. So first of all, Quality Committee. So I think there is a risk flagged here, isn't there? I'm going to go to you, Mark.
So can I just mention two things? We had the discussion earlier on about corridor care, temporary escalation spaces, and you will note that we have been discussing that at Quality Committee for some months, actually.
I can imagine.
It is a concern for us. The point we escalate is to do with the limited anaesthetic neonatal anaesthetist training available. Amanda can comment in more detail. I don't think we're actually asking the board to do anything, because we believe that there are any actions necessarily be in place, but we wanted to alert the fact that we have a concern in this space.
And just to add, I think what we need is Sean and I probably need to link with NHSE now in terms of the outputs from the clinical Senate work around neonatal anaesthesiology provision across the region.
Okay.
I think it is compromised.
Okay.
So, sorry.
Go.
So, I presume this links to the paediatric surgery,
neonatal
surgery.
Exactly.
And just for the board's knowledge, so the neonatal surgery, we're having to transfer patients out of hours. Because of the lack of neonatal anaesthetists.
Yes, and that's a national picture.
Yeah.
Okay.
But, and it's a big but for me. Bearing in mind this is part of a specialised commissioning, and that will be being from next year. North East North Cumbria will be holding that ring on specialised commissioning for us. There's a piece of work for us to do. It's part of the issues around the frailty of some of the tertiary services at Hull, and that there isn't vast volumes of neonatal surgery, and once you remove out of ours neonatal services, you then reduce the volume of neonatal surgery even more, which could potentially have a knock-on effect in terms of the viability of neonatal surgery services in Hull in its entirety.
Yeah.
And this has been something that we've been looking at with specialised commissioning for a while now, but I think we genuinely need a different approach, because it is, say, you start, it's like sort of shaving things off in terms of tertiary services, and suddenly
you've got tiny numbers.
then it'll be a knock on actually. So we haven't got the people to do that, and and it links to something else, and it becomes a bigger and bigger issue. So I think we need to have some.
We need that
hard discussions. We need clinical advice to sort that for the longer term.
Okay, and I guess from the point of view of the board, the risk has kind of been flagged to the board. There's clearly a set of actions and conversations that kind of need to take place. The board needs to be aware of the risk, but assured that the work is kind of being followed up. I suppose that's where we need to go with that one. So System Quality Group, nothing to kind of flag, but interested to see that, Amanda. Thank you for that. I think it's the first time we've seen System Quality Group insight reports kind of arriving here. So I think that's
we've always happened.
Have we?
Yes.
I don't remember them. Maybe I can read some. I don't know.
Always.
It's good to see them, Amanda.
Good.
It's going to be more memorable than ones I've seen before. I don't know what we did. I don't know what we're doing with the chief nurse before, guys. Yeah. What are we doing with the chief nurse? Whatever happened to her? Finance, performance and contracting. So, Simon, anything you want to kind of flag in here? We've already, I think, flagged that increasing the risk level because of the current financial position. Anything else you want to say on that?
So I think the discussion earlier was mostly focused on the in-year position. So it's just useful to mention the planning process. So the board approved the sort of draft plan, didn't it, in December? And just to highlight, the committee did have two sort of extraordinary sessions to go through that plan prior to it coming to the board. What I'd comment on is that we had a good level of assurance in terms of the ICB as a statutory body in terms of its financial plan. There's a lesser level of assurance about the ability to deliver all the performance standards next year because of issues in the providers.
Yeah.
And we do need to recognise that although we're moving into the new world and we've not got system control total at ICB level anymore, I would be very surprised if the providers are not having significant financial difficulty in the coming year with significant saving plans. And the way that will impact on the ICB is that, as a risk, is that they will seek to solve some of those issues through income. And I think contracting discussions, things like that, will be challenging. So just to note that risk. Yeah.
No, I think that's helpful to kind of flag that, and a huge appreciation to all the additional finance, performance and contracting committee meetings that have kind of gone into the diary. It feels like I see more of that committee than I do of anywhere else in the entire world. So, but I think that committee is doing the stuff that it kind of needs to do, and I kind of think it's put us from a board point of view. I think that sifting, that looking at the draft plan, I think has been really helpful in terms of our assurance around where we've got to with the draft plan as it stands. So massive appreciation for your leadership around that, Simon.
Thank you.
So remuneration committee, Mark, nothing to flag.
Nothing to add.
Clinical professional group. So I think we note that concern around organisational change, because I kind of think that is impacting on everybody, and I think that would be a risk for all of our committees within our organisation. Population health, I think Louise has gone, but population health, nothing to flag. And then I think in terms of digital, I'm conscious that Nigel is not here, and digital kind of sits with Nigel, but I think there are some issues kind of flagged in terms of the potential impact of restructure on digital data and the research kind of functions. There's something about data warehouse support, urgent migration. I think we probably just need to come back to these when we have Nigel within the meeting, just to get some assurance that these risks have actions attached to them and mitigations. I'm not sure if anybody feels they're able to answer those questions now and are a secret digital person, please tell us now. Otherwise, we'll come back to those with Nigel. But the insights report, I think, and I think there's a massive assurance to me that despite the change and the really difficult position we find ourselves in as an ICB, but also as a wider partnership, that actually this is really assuring me that the business that we need to do in terms of today is kind of being done, and actually there is a real impact in kind of what we're doing. So thank you to everybody who is leading this work through quite challenging times. Any other questions on the insights reports? But if we could just flag Michelle in terms of the notes, that we'll come back to the digital ones with Nigel at the next meeting, that would be really helpful. Okay, so items for information. So you've got the link through to all of the stakeholder bulletin as the good news stuff. Really high quality stuff. I think it shows a real diversity in terms of the stuff that we are doing. Anything particular? You've rested your voice for a bit, Anya. Anything particular that you wanted to croak around this? No? Okay, super. There for information. There is no any other business. Close remarks to the meeting. I mean, thank you for all of that kind of ongoing support that you've given us. Thank you for all your support in terms of getting to where we've got to in terms of our plan for next year. And we will have an opportunity to kind of pick up on some of the points that we've touched on this part of the meeting in the second part as well. I think there's nothing else to say apart from the fact that the date of the next public meeting will be the 11th of March, and that will be in public. And at this point, I move to exclude the press and the public in terms of the nature of the business that we now need to conduct in private. So thank you for your time this morning. I hope today has been useful.
Thank you.
Thank you.